Imagine a patient sitting across from you in the examination room. They look perfectly healthy.
Right.
You ask them to write a letter to their family, and they do so beautifully. The grammar is flawless. The handwriting is totally neat.
Totally coherent thoughts. Yeah.
Exactly. So they put down the pen, and then a minute later, you hand that exact same piece of paper back to them and ask them to read aloud what they just wrote.
And they can't do it.
They just can't do it.
Yeah.
I mean, they look at the page, their eyes work perfectly, their language skills are obviously intact, but they're completely text blind to their own handwriting.
It sounds like absolute science fiction, doesn't it?
It really does.
But it is a very real, very profound clinical phenomenon. It's called alexia without agraphia.
Right.
And it represents one of the most stunning examples of how the architecture of the human brain dictates human experience.
So today, for our deep dive, we are exploring the exact fault lines in the brain that make scenarios like that a reality.
It's a fascinating topic.
It really is. I want you to think of the human condition like a tectonic fault line.
Okay, I like that.
So deep underground, you have the raw, massive, ancient biological mechanics of the Earth grinding away.
Right, the anatomy, the neurotransmitters.
Yes, the structural hardware. And then built directly on top of that fault line, you have the fragile, intricate cities of the surface.
The roads, the buildings, the culture.
Exactly, which is the mind, our lived experience, our personality, our behavior.
And when there is a tremor deep down in that biological bedrock, it inevitably, fundamentally reshapes the landscape of the city above.
Yeah, that's spot on.
I mean, sometimes it's a massive earthquake, like a severe traumatic brain injury.
Yeah.
But sometimes it's just a really subtle shift, a microscopic stroke in a single white matter tract that just cracks the foundation of a specific psychological function.
Which brings us to the core mission of this deep dive today. We are looking at the neuropsychiatric approach to the patient.
And we should clarify, we aren't just going to rattle off a list of diagnostic criteria today.
Oh, absolutely not. We're drawing from Chapter 2.1 of Kaplan and Sadok's comprehensive textbook of psychiatry.
Right.
And the goal here is to build mental models. We want to understand the mechanisms of how the brain, the mind, and lived experience interact.
And precisely how that process can go wrong.
Yes.
Because historically, it felt like psychiatry and neurology lived in completely different universes.
Yeah, they really did.
For a large part of the 20th century, general psychiatry dealt with what we might call the idiopathic realm.
The chemical soups.
Exactly. Conditions conceptualized as neurotransmitter imbalances or developmental trajectories where if you took a standard MRI, the brain looked totally normal.
Whereas neurology took the structural stuff, the strokes, the tumors.
Measurable decay, yeah.
But what struck me as we prepared for this is that neuropsychiatry isn't actually a new invention.
No, not at all.
It's a reclamation of the very original vision of the field. I mean, if you look back at the asylum physicians of the 19th century.
The precursors to modern psychiatrists.
Right. They absolutely considered their patients to be suffering from brain diseases. They were treating things like general paresis of the insane.
Which we later discovered was just the end stage of neurosyphilis.
Exactly. And they were treating epilepsy, the severe neurological complications of alcoholism, acquired brain diseases.
Precisely. They approached the patient not just as a psychiatric category, but as a complex biological system.
Right.
And that is the paradigm shift we are discussing today. If the general psychiatric brain is often thought of as this diffuse chemical soup,
where a bit of an imbalance here affects mood globally.
Yeah, the neuropsychiatric brain is entirely different. It is a highly differentiated network of very specific circuits.
So it's not just a drop of dye changing the color of the whole pool.
No. It operates on the foundational principle that where something happens is just as important as what is happening.
It's like a specific wire being cut in a massive server farm.
Spot on. A microscopic stroke in a highly specific basal ganglia circuit will produce a highly specific, predictable change in how a person initiates action.
Or experiences empathy.
Exactly. And this brings us to a word that has a fascinating, somewhat controversial history in medicine, the word organic.
Ah, yes.
Yeah?
Organic. The official diagnostic manuals dropped it years ago for psychiatric conditions.
They did. But if you walk the halls of any hospital, you still hear clinicians use it constantly in the vernacular.
I hear it all the time. Is this presentation functional or is it organic?
Right.
Why does that word refuse to die?
It persists because the concept it represents is incredibly useful. It demands a specific clinical toolkit.
What do you mean by that?
Well, when a physician says organic today, they are referring to acquired brain diseases where the pathology can be objectively identified.
At the bedside or in a lab.
Yes. We are talking about traumatic brain injury, movement disorders like Parkinson's or neurodegenerative dementias.
And treating those requires an understanding of neuroanatomy that a general psychiatrist treating standard depression might not use every day.
Exactly. But I want to plant a flag right here because there is a massive conceptual trap we could fall into.
The reductionist trap.
Yes. When we start talking about organic brain disease and broken hardware, it is incredibly easy to just become reductionist.
To look at a patient and say, well, they have a lesion in their frontal lobe, so their psychological trauma doesn't matter anymore.
Right. Oh, it's just a broken machine. But that is the exact opposite of the neuropsychiatric philosophy.
Right, because treating a condition as brain-based does not depreciate the role of psychological and social factors.
Not at all. In fact, individuals with brain disease are often vastly more dependent on their social world than a healthy person.
Because their internal tools for navigating the world are compromised.
Exactly. Much of our brain's highly evolved real estate is devoted to processing social information.
Reading subtle cues in a room, understanding tone of voice.
Figuring out how to meet our internal needs within a complex community. So if a brain-based impairment degrades your ability to process that information...
Your reliance on others goes up exponentially.
It does. You need a structured, supportive context just to survive the day.
I like to think of it like a musician and their instrument. So imagine your mind, your personality, is a master musician.
Okay.
And the brain, the biology, is their instrument. Let's say it's a beautifully crafted violin.
Right.
If that violin has a cracked sounding board or a snapped string, the song the musician plays is going to change dramatically.
It might sound dissonant or incomplete.
Exactly. Now, you absolutely cannot treat the song without inspecting the violin. You have to look at the hardware.
But fixing the violin doesn't automatically write the music.
That's exactly it.
That is a beautiful way to frame it. Neurological signs without their psychological context are totally incomplete.
Right. You can diagnose the snap string, but you still have a human being who has to learn to play their life again.
In a new context, with new limitations. And conversely, psychological symptoms without biological grounding risk terrible misinterpretation.
If you don't notice the snap string, you might blame the musician for deliberately playing out of tune.
Exactly. The neuropsychiatric approach refuses to split the two. It demands we evaluate both the instrument and the song.
So to inspect this instrument properly, we really have to understand how it is wired.
We need to move from the abstract to the anatomical.
Right. And I want to start with a concept that everyone has heard of, but almost everyone gets wrong.
Lateralization.
Yes. The old left brain versus right brain dichotomy. We've all seen the pop psychology articles, right?
Oh, constantly. The left brain is the boring, logical accountant, and the right brain is the free-spirited artist.
Exactly. So we need to discard that myth immediately.
We do. But throwing out the pop psychology doesn't mean we throw out the concept entirely.
Right, because there are very real regional lateral asymmetries in the brain.
Yes. Our two hemispheres do have different processing styles and dramatically different responsibilities.
Let's get into the reality then. Obviously, the left hemisphere generally handles language.
Specifically in the pars opercularis of Broca's area, yeah.
Which is actually physically larger with more complex branching on the left. But what are the subtle differences that actually impact survival?
Let's look at the autonomic nervous system. This is where it gets incredibly concrete.
Okay, the system that controls heart rate, digestion, internal organs.
Right. Deep inside the brain is a region called the insular cortex.
The insula.
Yes. The insula in the right hemisphere primarily regulates your sympathetic drive. That's your fight or flight response.
The system that revs your heart rate up.
Exactly. But the insula in the left hemisphere regulates your parasympathetic drive, your rest and digest system.
The brakes that calm your heart down. Wait, so the physical halves of the brain control opposite halves of the body's physiological pacing.
Yes.
What happens if someone has a stroke there?
It dictates their physiological survival. Say a patient suffers a stroke in the left hemisphere that destroys the left insula.
They lose a significant portion of that parasympathetic calming control.
Exactly. What is the result? Unopposed sympathetic drive from the right side.
Their nervous system is stuck on the accelerator.
Clinically, these patients experience significantly more cardiac destabilization, dangerous arrhythmias, and overall morbidity.
Compared to a patient who has the exact same size stroke, but on the right side.
Spot on.
That is astonishing. The exact same injury, just shifted a few inches to the right, fundamentally changes whether the heart destabilizes.
It really highlights why localization matters.
And I imagine this plays out in the endocrine system, the hormones as well.
It does. There are distinct lateral differences in how the amygdala and the hypothalamus regulate hormones and sexual function.
Give us an example of that.
Well, women with polycystic ovary syndrome, or PCOS, have been observed to have higher rates of left-sided limbic epilepsy.
Wow, so the brain's lateralized regulation of hormones is deeply interconnected with systemic disease.
Absolutely.
What about emotions? If the whole artist versus accountant thing is a myth, is there any truth to a left-right divide in how we feel?
There is, but it's wonderfully counterintuitive. Traditionally, the left hemisphere is actually tied to positive emotions.
Okay.
However, in the context of trauma or brain injury, left hemisphere damage or overactivation can manifest as anger and hostility.
And the right hemisphere?
The right is tied to negative emotions and to depression and anxiety following a traumatic brain injury.
So if I injure my right hemisphere, I'm statistically more prone to depression.
Yes. But the right hemisphere does something even more fundamental.
It seems to be the dominant force for processing emotion overall, right?
It is. It has a prepotent role in reading the room. It perceives emotion, regardless of whether it is positive or negative.
Spoken or visual.
Exactly. So if someone sustains damage to the right hemisphere, they might develop a fascinating and tragic condition called aprosodia.
Aprosodia, the loss of the emotional melody in speech.
Yes.
How does that actually present in a conversation?
Imagine you are talking to someone and their voice is completely flat, robotic. They might be telling you the most joyful news of their life.
Or expressing profound grief.
Right, but the acoustic envelope of their voice doesn't change at all. That is expressive aprosodia.
But the receptive side is even more devastating, isn't it?
It is. They lose the capacity to recognize those intonations in you. You could be crying, your voice cracking with sadness.
And their brain just registers the visual fact of tears.
And the semantic meaning of your words, but it will completely fail to process the emotional weight.
They become deaf to the melody of human feeling.
Because the specific module for decoding emotional acoustics is broken.
It really drives home the idea of the brain as a collection of specific circuits.
It does.
Which leads us perfectly into the deeper architecture, the fronto-subcortical circuits.
This is a foundational model for any clinician. You can think of these circuits as a series of specific subway lines.
Okay, subway lines.
They start in the highly evolved newer prefrontal cortex, the surface of the brain. The tracks run deep down into the older subcortical structures.
The striatum, the basal ganglia, and the thalamus.
And then, crucially, the thalamus writes the signal right back up to where it started in the cortex.
So it's cortex, striatum, basal ganglia, thalamus, back to cortex. It's a closed parallel loop.
Exactly. And there are three main loops that dictate human behavior.
Let's start with the one that acts like the brain's RAM, the dorsolateral prefrontal circuit.
Right. The dorsolateral prefrontal cortex is located on the outer upper surface of the frontal lobes.
And this circuit is essentially the CEO of the brain, isn't it?
It is. It handles executive cognitive function, working memory, complex problem solving, sequencing, and organizing information.
So, if I'm understanding this right, if this circuit is like the RAM in a computer, it doesn't matter if my hard drive, my long-term memory is fine.
Correct.
If the RAM is fried, I can't even hold a phone number in my head long enough to write it down.
That is exactly what happens. When this loop is damaged, you see executive cognitive impairment.
Whether that's from a traumatic brain injury or a small vessel disease.
Or diseases like Parkinson's that attack the basal ganglia deep down in the loop. The patient looks disorganized.
They can't plan out a sequence of actions, like following a recipe?
We often term this a subcortical dementia. Their raw intelligence might be intact, but their ability to manipulate information in real time is gone.
Okay, that's loop one. Loop number two is the orbitofrontal circuit.
Yes. This is the part of the brain sitting right above the eyes.
And while the first loop was the CEO, this loop is the HR department, the compliance officer.
That's a great way to put it. It manages inhibition, social judgment, and emotional regulation.
This is the famous Phineas Gage area, isn't it?
Yes. The 19th century railway worker who had a massive iron rod blown straight up through his cheek and out the top of his skull.
Destroying this exact region. He survived, but his friend said he was no longer Gage.
Precisely. When you damage the orbitofrontal cortex, the patient becomes profoundly impulsive and disinhibited.
They might make highly inappropriate sexual comments, swear profusely, or shoplift.
And their baseline experience of emotion is often blunted, but they are highly reactive and irritable.
And crucially, they lack insight.
Right. They have absolutely no idea that their behavior is socially catastrophic.
And there is a really specific physical clue you look for here, a neighborhood sign.
Ah, yes. Because this part of the brain sits right above the nasal cavity, damage here often involves the olfactory nerve.
The nerve for smell.
Yes, it runs right along the orbital surface of the brain, literally resting on the bone above the nose.
So if a patient has a tumor pressing there, or a head trauma where the brain scraped against that bony ridge,
They often develop anosmia, the total loss of the sense of smell.
this is where clinical reasoning becomes an art form.
It really is.
If a patient comes into your clinic acting incredibly impulsive, making rude comments, showing terrible social judgment, you don't just ask about their childhood.
You ask if they can smell their morning coffee.
It is brilliant localization.
If they are disinhibited and they also have anosmia, you are not dealing with a sudden onset personality disorder.
You are dealing with a structural lesion in the orbitofrontal region until proven otherwise.
And the trap here is that if you give this patient standard bedside cognitive tests, they will pass.
Asking them to remember 3 words or draw a clock face.
They will perform perfectly, their memory and spatial skills are fine, but their personality is devastated.
Wow. Okay, the third loop, the anterior cingulate or dorsomedial circuit. Where is this and what does it do?
This circuit originates on the inner medial surface of the hemispheres, right where the two halves of the brain face each other.
And this circuit is the starter motor of the human mind.
Yes. It is responsible for motivation, the initiation of action, and sustained attention.
It connects deeply down into the ventral striatum, which is a major reward center.
Correct. So if the starter motor is broken, the car won't turn on even if there's gas in the tank.
What does that look like in a human?
It creates a spectrum of motivation failure. At the milder end, you see apathy.
And in the middle?
You see abulia, which is a profound pathological lack of will or drive to do anything.
At the most extreme end of the spectrum, if this circuit is completely destroyed, what happens?
You see akinetic mutism.
Akinetic mutism.
Yeah.
Movementless, speechless.
Yes. The patient is awake, their eyes are open, they track you across the room, they are not paralyzed.
Their motor cortex works perfectly fine.
But they simply do not initiate movement or speech. The internal command to act, the spark of agency, is gone.
And this circuit relies heavily on a very specific type of cell, doesn't it?
Yeah.
The spindle cell.
Yes, or the von Economo neuron. These cells are fascinating from an evolutionary perspective.
They're found almost exclusively in the anterior cingulate and the frontoinsular cortex,
And in human development, they don't even appear until a baby is about 4 months old.
which is exactly the age when an infant begins to sustain focused attention on their mother's face.
Exactly. They are the neurobiological substrate for sustained, directed attention.
And we know that these specific cells are selectively targeted in certain diseases.
Yes, specifically frontotemporal dementia. As those cells die off, the profound loss of attention, empathy, and social engagement becomes glaringly obvious.
On the flip side, if this circuit is overactive, you get excessive rigid attention.
A brain that is stuck on.
In fact, surgically interrupting this circuit, a cingulotomy, can be a last resort treatment for severe OCD.
That's right.
So we've mapped the frontal loops, the RAM, the compliance officer, the starter motor. But let's move deeper into the brain's emotional engine room.
The limbic system and the cerebellum.
Yes. The limbic system is famous for emotion and memory. The amygdala, the hippocampus.
Yeah.
But from a neuropsychiatric perspective, what stands out is its electrical volatility.
The limbic system is incredibly prone to electrical storms.
The amygdala and the hippocampus have the absolute lowest threshold in the entire human brain for producing epileptic discharges.
Because of this, the vast majority of adult-onset epilepsy is actually limbic epilepsy, often originating in the temporal lobe.
And because it's happening deep in the emotion and memory centers, a limbic seizure doesn't look like the classic seizure we see on television.
No, the patient doesn't necessarily fall to the ground and shake. They often remain upright and conscious.
But their subjective reality violently alters.
Yes. John Hewlings-Jackson, a brilliant pioneering neurologist, coined a term for the aura of a limbic seizure.
The voluminous mental state.
The voluminous mental state, yes.
What is actually happening in the patient's mind during that?
It is a profound, overwhelming rush of complex experiential phenomena. It can manifest as intense déjà vu.
The unshakable feeling that you have lived this exact moment before.
Or the terrifying opposite, jamais vu, where your own living room suddenly feels completely alien and unrecognizable.
It can involve depersonalization, where you feel detached from your body.
Or derealization, where the world feels like a two-dimensional movie set. They might even experience macrypsia or micropsia.
Where objects in the room suddenly swell to terrifying sizes or shrink away.
Eh.
That sounds absolutely terrifying. It sounds like a severe, acute psychotic break.
And that is exactly why clinicians must be so careful. These voluminous mental states are classic signs of a limbic seizure.
But they are not exclusive to epilepsy.
Not at all. The exact same symptoms, dissociation, depersonalization, derealization, are seen in patients with severe mood disorders.
And borderline personality disorder.
And crucially, in adults with a history of severe childhood trauma and abuse.
Wait, so a history of childhood abuse can create the exact same subjective symptom profile as an electrical storm in the hippocampus?
Yes. The presence of these symptoms points to profound limbic distress. It tells you where the distress is manifesting.
But it doesn't automatically tell you what the underlying etiology is.
Right. Is it an acquired electrical misfire, or is it a psychological adaptation to trauma encoded into the limbic wiring?
The neuropsychiatrist has to investigate both.
Absolutely.
Let's shift to the cerebellum. If you ask a medical student what the cerebellum does, they will tell you it's the brain's shock absorber.
It sits at the back of the skull, and it coordinates physical movement.
It keeps you balanced and makes sure your reach is smooth.
And that is entirely true for the newer parts of the cerebellum, the neocerebellar hemispheres.
But right in the midline, tucked between those hemispheres, is an older structure called the vermis.
And modern imaging has provided overwhelming evidence that the vermis acts as a limbic cerebellum.
A limbic cerebellum. So the balance center also balances our emotions.
It's a perfect analogy. The cerebellum has massive projections connecting it to the prefrontal cortex and the limbic system.
When patients have isolated strokes confined entirely to the cerebellum, they don't just get physically clumsy.
No, they develop what we call cognitive dysmetria.
Dysmetria usually means you reach for a cup and miss it because your physical aim is off. What is cognitive dysmetria?
It means your emotional and cognitive aim is off. These patients show executive deficits. They struggle to plan.
And crucially, they show profound affect dysregulation.
They become highly irritable, emotionally labile, prone to sudden outbursts.
Their emotional coordination is as clumsy as their physical coordination.
Exactly. But mapping this is incredibly tricky because of a phenomenon called crossed cerebellar diaskesis.
I want to make sure we explain this clearly because it is mind-bending. Let's use an analogy.
Okay.
Imagine two cities, City A and City B, connected by a massive trade highway.
Right.
City A produces all the raw materials, and City B processes them. If a massive earthquake destroys City A goes dark. But what happens to City B?
City B wasn't touched by the earthquake. But because the trade highway is completely severed, City B starves.
Its factories shut down, its economy collapses, it falls into a depression simply because it lost its vital input.
And that is diaskesis.
Exactly.
In the brain, the right cerebellum, which is City A, is deeply densely connected to the left cerebral cortex, City B.
Via massive white matter highways.
If you have a stroke that damages your right cerebellum, the left cerebral cortex suddenly loses a massive amount of stimulating input.
In response, the left cortex functionally shuts down, its blood flow drops, its metabolism plummets.
Even though the left cortex itself is physically perfectly healthy.
Wow.
Yes, it is a loss of function in a distant, healthy brain region due to a loss of connectivity.
So when a researcher sees a patient with a cerebellar lesion exhibiting cognitive impairment, they have to ask a very difficult question.
Is the cerebellum directly responsible for processing this complex thought? Or is the cerebellum just failing to stimulate the prefrontal cortex?
Which is the actual engine of the thought. It makes localizing function incredibly treacherous.
It really does.
Speaking of localizing function, let's look at the cerebral cortex and the idea of modularity.
The concept that specific functions live in specific boxes.
The visual system provides a great example of this with the what and the where pathways. How does that work?
When visual information enters the brain, when you look at a cup of coffee on your desk, the data hits the primary visual cortex at the very back of your head.
But from there, the data stream splits into two distinct rivers.
The dorsal stream goes up into the superior parietal lobule. This is the where pathway.
It calculates the spatial coordinates, exactly where that cup is in three-dimensional space.
And the ventral stream goes down into the inferotemporal cortex. This is the what pathway. It accesses your semantic memory to identify the object.
So what happens if I have a specific injury to the dorsal stream, the wear pathway?
You develop optic ataxia. Your ventral stream works perfectly, so you can look at the cup and say, that is a white ceramic mug filled with coffee.
You know exactly what it is.
But because your wear pathway is broken, you cannot integrate that visual identity with your motor output.
When you reach for the cup, your hand misses wildly. You grasp at empty air.
And the reverse.
Right, if I damage the ventral stream, the what pathway?
You develop visual agnosia. Your spatial mapping is pristine, your reach is perfectly accurate, your fingers wrap around the handle flawlessly.
But you look at the cup of coffee and have absolutely no conscious idea what it is.
Or what it is used for, until perhaps you touch it and feel the heat or smell the coffee, allowing your other sensory modalities to fill in the blank.
It's fascinating. It feels very neat and tidy. One box for where, one box for what.
It does.
And this leads to the concept of modularity, the idea that the brain is like a smartphone with a collection of specific apps, each with dedicated hardware.
But the current science provides a pretty sharp critique of strict modularity, doesn't it?
Yes, the expert consensus warns heavily against neophrenology.
The idea that every complex, nuanced human behavior has a tiny, dedicated 1-inch square box in the brain.
Right. Complex cognitive functions are not isolated modules. They are selectively distributed networks.
And the brain's physical structure is not fixed from birth. It is a dynamic, developing ecosystem.
The best example of this is a genetic condition called Williams syndrome. This completely flips the idea of hardwired modules on its head.
Williams syndrome is a fascinating developmental disorder. In adults with Williams syndrome, you typically see a very specific, stark cognitive profile.
They have severe impairments in spatial and mathematical processing.
They struggle immensely to draw simple shapes or navigate space.
But conversely, they have exceptionally strong, almost hyperfluent language skills and often a profound affinity for music.
So if you were a strict localizationist, a neophrenologist, you would say, it's obvious. The maths module is broken, but the language module is intact.
Exactly. But here is the mechanism that breaks that theory. If you test infants with Williams syndrome, you find the exact opposite profile.
In infancy, their language development is actually severely delayed, and their spatial understanding appears relatively stronger.
Wait, how does it flip over 15 years? How does the hardware rewrite itself?
Because brain regions aren't hardwired modules from birth, they become tuned over time based on connectivity, competition for resources, and experience.
In Williams syndrome, the fundamental genetic disruption alters how the entire brain develops.
Because the infant's language processing is initially so delayed and inefficient, the developing brain aggressively recruits massive amounts of neural real estate.
It pours all its developmental budget to auditory and verbal processing to catch up.
By adulthood, this overcompensation results in hyperfluent language, but it leaves the spatial processing areas starved of developmental resources.
The brain rerouted itself.
Mm-hmm.
You cannot say a single module was knocked out by the gene.
A vast expanse of nonlinear neuroplasticity lies between the genetic code and the adult clinical picture.
The brain quite literally rewires its purpose. And that brings us to the actual wiring itself, white matter and connectivity.
We spend so much time talking about the gray matter, the computers, that we ignore the cables.
But white matter makes up 42% of the human hemisphere.
Yes, and the cables are just as vital as the computers. We have massive long tracts, like the arcuate fasciculus, which acts as a broadband cable connecting the frontal and temporal lobes for language.
And we have U fibers.
Tiny, short, local connections that loop beneath the surface to connect adjacent folds of the cortex.
And different diseases target these cables differently. Hypertensive small vessel disease destroys the long tracts deep in the brain, but often spares those superficial U fibers.
But the most dramatic examples of white matter issues are the disconnection syndromes.
Which brings us back to the scenario we opened the show with. Alexia without agraphia. The inability to read without the inability to write.
Let's explain the mechanism behind the science fiction scenario.
Okay.
It is a stunning, tragic example of neuroanatomy. This phenomenon occurs when a patient suffers a stroke in a very specific artery, the left posterior cerebral artery.
This single stroke does two devastating things simultaneously. First, it destroys the left visual cortex at the back of the brain.
Now, because of how our eyes crosswire, the left visual cortex processes the right half of the world.
So if the left visual cortex is dead, The patient is now blind in their right field of vision. They can only see the world using their surviving right visual cortex.
Correct. They can still see the words on the page, but all that visual data is now exclusively entering the right hemisphere.
Right.
But here is the second thing the stroke does. It destroys the splenium.
The splenium is the posterior or back part of the corpus callosum. The corpus callosum is the massive white matter bridge connecting the left and right hemispheres.
So the bridge is out.
Yes.
The visual information of the written word enters the right visual cortex perfectly fine. The visual processing is flawless.
But language comprehension, the ability to decode written symbols into meaning, is overwhelmingly located in the left hemisphere.
Because the splenium is destroyed, the visual information is physically trapped in the right side of the brain. It cannot cross the bridge to the language center.
So they're looking at the word, they can trace the letters, but the language center never receives the visual input to decode it. They cannot read.
Exactly. But why can they still write?
Because the left language center itself is perfectly intact, and its outgoing connections down to the motor cortex to control the right hand are also perfectly intact.
The language center can output commands to write, but it is completely disconnected from incoming visual input. Alexia without ongraphia.
It is the ultimate proof that connectivity matters as much as the cortex itself.
It really is.
And this leads us to the modern frontier of neuroscience, brain networks. We aren't just looking at isolated tracks anymore. We are looking at large, synchronized functional networks that span the whole brain.
Right. Functional MRI has allowed us to see these large-scale networks operating in real time. The most famous is the default mode network, or DMN.
This involves the medial prefrontal cortex and the posterior cingulate.
The DMN is active when we are reflecting, daydreaming, or retrieving episodic memories about our own lives.
And crucially, this specific network is preferentially targeted and degraded by Alzheimer's disease.
Then there's the salience network, centered on the anterior cingulate and anterior insula.
It acts as the brain's triage system. It tells us what is important in our environment, what we should care about.
This network is preferentially destroyed by behavioral variant frontotemporal dementia, which is exactly why those patients become emotionally blunted and socially indifferent.
And understanding these networks solves a massive historical headache for neurologists. The text mentions a technique called lesion network mapping. What problem did this finally solve?
It solved the wrong location problem.
Tell us about that.
For decades, a neurologist would examine a patient with a specific bizarre symptom, let's say a highly specific delusion. They would look at the MRI, expecting to find a lesion in the delusion module.
But they would find 5 different patients with the exact same delusion, and their lesions were in 5 completely different geographic locations in the brain.
It was maddening. It made localization seem impossible.
So the strict localization theory failed completely.
Right. But lesion network mapping changed the game. Instead of just looking at the lesion, researchers map the healthy human connectome.
They ask, what entire network of brain regions is normally connected to lesion site A?
And then what network is connected to lesion site B? What they found is a revelation.
Even if the lesions are geographically distant, they all intersect and disrupt the exact same functional network.
The symptom isn't caused by damage to a specific geographic box. It's caused by illusion breaking any link in the chain of the network that supports that function.
That is an incredible synthesis of everything we've talked about.
Yeah.
Okay, we have mapped the tectonic plates, we've looked at the circuits, the lateralization, the networks.
Now we have to transition from the anatomy textbook to the exam room.
How do these invisible structural mechanisms actually manifest in a patient sitting in front of you? Let's talk about clinical evaluation, starting with the neuropsychiatric history.
The history is a targeted search for the organic fingerprint. We aren't just asking, how do you feel?
We're looking for specific temporal and functional patterns that reveal the state of the underlying machinery.
Let's take paroxysmal disorders, things that happen in sudden episodes or attacks. The classic differential diagnosis here is an epileptic seizure versus a panic attack versus a psychogenic non-epileptic seizure, or PNES.
How does the clinical history separate them?
You have to track the chronology of the event with forensic detail. Epileptic seizures typically have an abrupt, instantaneous onset. The brain's electricity suddenly surges.
Panic attacks, however, usually have a more gradual crescendo, building up over minutes to a peak intensity.
You ask about the aura. Did they experience that voluminous mental state before the event?
But differentiating epilepsy from PNES is notoriously difficult.
PNES events are incredibly real, deeply distressing events, often linked to severe trauma, but they do not involve abnormal electrical discharges in the cortex.
And the complication is that sometimes patients have both.
Yes, a sizable minority of patients with PNES also have comorbid epilepsy. But here's a clinical pearl from the neuropsychiatric approach.
What's that?
Sometimes, if you simply ask the patient, do you have two different kinds of seizures, they will say yes.
And they will proceed to describe one event that is classically neurologically epileptic and another event that is functionally driven. The history is everything.
It really is.
Let's talk about cognitive symptoms, specifically memory. Think about a busy psychiatric clinic. Almost every patient who comes in with severe depression will say, "My memory is terrible, my brain is broken."
I can't remember anything.
Right. How do you know if it's the depression or if it's an early organic disease like Alzheimer's?
It's one of the most common dilemmas. In depression, the subjective complaint of memory impairment is often intense and vocal.
But if you sit them down and formally test them, providing cues and structure, they actually perform reasonably well.
Their core issue is usually attentional failure. Their mind is so consumed by depressive rumination and psychic pain that they aren't encoding the new information in the first place.
And in organic disease, what is the red flag?
In organic disease, the complaints are often less intense because the patient is losing insight, but the functional loss is highly specific. A major red flag is the loss of the capacity for divided attention.
Divided attention. Think about your own morning commute. You're driving your car, you're listening to this deep dive, maybe you're internally planning your first meeting.
You are seamlessly dividing your attention.
Exactly. And a patient with an organic degradation will tell you, "I used to be able to read the newspaper and listen to the radio, but now I can't do both."
Or they lose automaticity in highly familiar tasks. They get lost driving home from the grocery store they've visited for 20 years.
That points to a structural degradation of the network, not just a distraction from mood.
What about sleep? I always feel like sleep is the purest window into the brain's baseline health because the conscious mind is out of the way.
Absolutely. The profound implications of parasomnia's abnormal movements or behaviors during sleep cannot be overstated.
If a patient comes in, or usually it's their spouse who brings them in, reporting that the patient is acting out their dreams, punching, kicking, flailing in bed.
That is REM sleep behavior disorder.
Normally, during REM sleep, a specific nucleus in your brainstem paralyzes your body's motor neurons so you don't act out your dreams.
If that atonia is lost, it points to a specific anatomical lesion in the pons.
And if there isn't an obvious structural lesion there,
Then idiopathic REM sleep behavior disorder is one of the strongest known clinical predictors of an ingravescent synucleinopathy.
most notably Lewy body disease or Parkinson's disease.
The degeneration of those specific brainstem nuclei can precede the classic cognitive or motor symptoms by a decade. The sleeping brain warns us years before the waking brain does.
There is an even more terrifying sleep disorder mentioned in the literature, oneric stupor.
Yes, this is exceedingly rare but devastating. Instead of violently acting out an aggressive dream, the patient is in a bizarre, stuporous state at night, automatically pantomiming their daily, repetitive waking tasks.
The clinical literature gives examples like an orchestra conductor moving his arms in his sleep, or a tailor sewing imaginary fabric.
This is often a cardinal sign of fatal familial insomnia, a rapid, untreatable neurodegenerative prion disease. The barrier between waking behavior and sleep is completely dissolved.
Let's move to the physical examination. We are looking for motor signs, but it's very clear that we aren't just looking for classic weakness.
We are looking for non-pyramidal signs.
Right. Pyramidal weakness is your classic stroke, picture unilateral paralysis, spasticity, brisk reflexes.
But neuropsychiatrists are deeply interested in the extrapyramidal and frontal motor systems, which dictate the quality and initiation of movement.
We look for clumsiness or a decrease in spontaneous facial expression. We look for pronator drift.
You ask the patient to hold their arms straight out, palms facing up to the ceiling, and close their eyes.
If one arm slowly pronates, turns inward, and drifts downward, that is a subtle, irrefutable sign of a contralateral brain lesion affecting motor control.
We ask them to rapidly tap their fingers or perform alternating hand movements.
What struck me is how incredibly fast this is. A skilled clinician can test major fronto-subcortical circuits in about 3 minutes.
Hold out your arms, close your eyes, touch your nose, tap your hands.
Exactly. In 3 minutes, you have assessed postural tremor, cerebellar dysmetria, complex motor sequencing, and the integrity of the premotor cortex.
What about soft signs? The face-hand test is a fascinating one.
This is a test of sensory extinction. You have the patient close their eyes. You gently touch their left hand and their right cheek simultaneously.
If their parietal networks are healthy, they will accurately report both touches.
But if they consistently only report the touch on the face, and their brain extinguishes or completely ignores the touch on the hand, that is a highly pathological sign.
It points to parietal lobe dysfunction, a failure to integrate simultaneous stimuli, and is often seen in severe schizophrenia or early dementia.
And then there are the reflexes, the Babinski sign.
The shibboleth of neurology. You stroke the bottom of the foot. If the big toe extends upward while the others fan out, you have a lesion in the corticospinal tract.
But the neuropsychiatrist has to be careful with nuance. You might see a striatal toe.
An upward extension of the toe that happens spontaneously in Parkinson's disease without pyramidal damage.
Or a plantar grasp, where the toes curl downward to physically grab the stimulating object.
Which is a frontal release sign, a primitive reflex that the damaged frontal lobes can no longer inhibit.
Speaking of failing to inhibit things, let's talk about testing executive dysfunction. This is where the patient's behavior in the exam room tells the entire story.
Yes. You look for motor and persistence, you ask the patient to close their eyes tightly or stick out their tongue, and they just cannot sustain the action.
They keep peeking, or the tongue immediately darts back in. They cannot maintain the executive command.
You look for perseveration.
Getting stuck in a behavioral loop.
Right. You test this with conflicting tapping tasks. You tell them, tap your hand once when I tap twice, and tap twice when I tap once.
It requires them to hold a rule in their working memory, inhibit their natural urge to mimic you, and execute the opposite action.
If they fail and just start blindly copying your taps, they are perseverating.
Right.
They cannot shift their cognitive set.
Which is intimately related to echopraxia.
Exactly. The patient crosses their arms simply because you cross your arms. They are failing to inhibit the environmental stimulus. Their behavior is hijacked by what they see.
The most dramatic example of this is utilization behavior. I love this clinical example.
You are sitting at the desk taking a history. You casually take out your pen and set it on the desk between you.
The patient, without being asked, immediately reaches out, picks up the pen, and starts scribbling on your notepad.
It is a profound, fascinating failure of executive inhibition. In a healthy brain, the orbitofrontal cortex says, that is not my pen, it belongs to the doctor, it is socially inappropriate to grab it.
But in utilization behavior, the orbitofrontal circuit is damaged. The mere visual affordance of the object, the brain recognizes it's a pen, and a pen is meant to be written with, compels the action automatically.
They are environmentally bound. They are slaves to the objects around them.
Okay, we have our history, we have our physical exam. Now we reach the integration and clinical reasoning phase.
This is where we separate the wheat from the chaff, where we bring the mind and brain together. Let's look at disordered mood and emotion.
We touched on this earlier with the anterior cingulate starter motor loop, but the clinical distinction between apathy and depression is critical here.
It is perhaps one of the most important and frequently missed clinical distinctions a neuropsychiatrist makes. To the untrained eye, they look identical.
Both an apathetic patient and a severely depressed patient lose interest in activities. They withdraw. They sit in a chair staring at the wall all day.
But internally, their subjective experience is entirely different. I think of it as empty versus full.
Precisely. Apathy, which is often caused by dorsomedial frontal damage, is a state of being mentally empty.
There is no drive, no motivation, but crucially, there is also no sadness, no guilt, no psychic pain. They are completely content to sit in the chair.
Depression, however, is a state of being mentally full of negative rumination, unbearable distress, and visceral anguish. They sit in the chair because they are crushed by the weight of their own mind.
And the treatment implications are massive.
Night and day. If you give a standard SSRI antidepressant to an apathetic patient, it will likely do absolutely nothing.
Or it might even make them more lethargic by blunting their remaining dopamine.
They don't need a serotonin boost to lift a heavy mood. Their mood isn't heavy, it's absent. They often need dopaminergic agents or stimulants to jumpstart their broken motivational circuitry.
What about depression that is directly linked to brain injury or disease? There's a specific network model for organic depression.
Converging evidence from neuroimaging shows that organic depression involved a distributed network with two main compartments acting in opposition.
The dorsal compartment, which includes the dorsolateral prefrontal cortex and parietal cortex, is severely underactive.
This explains the cognitive slowing, the poor memory, the lack of focus in depressed patients.
Conversely, the ventral compartment, the insula, The subgenual cingulate, the amygdala, is pathologically overactive.
This overactivity drives the somatic and vegetative distress, the intense visceral pain of depression. It is a system completely out of balance.
Let's talk about social behavior and theory of mind. We are returning to the right hemisphere again.
Theory of mind is arguably our most complex cognitive achievement. It is our capacity to understand that other people have different thoughts, intentions, and beliefs than we do.
It's how we detect deception or understand pretense. This function relies heavily on networks involving the right medial prefrontal cortex and the amygdala.
So a lesion in these networks causes what?
A profound disorder of pragmatics. The patient's basic language is fine. They can understand the grammar of your sentence perfectly.
But they cannot grasp your underlying intent. They fail to recognize sarcasm. They don't understand when a statement is intended as a joke, taking everything completely literally.
They lose the subtle, unwritten rules of human interaction, which is absolutely devastating for their marriages and friendships. They become socially blind.
Okay, let's move into the truly bizarre presentations. Abnormalities of agency and delusions. Let's start with agency. That fundamental feeling that I'm the one moving my body, that my hand belongs to me.
When the networks that compute agency break down, you see terrifying phenomena like the alien hand.
With a parietal lesion, or a lesion severing the corpus callosum, the patient's hand might literally levitate off the bed on its own.
Or it might engage in intermanual conflict, where the patient's left hand tries to unbutton a shirt while their right hand is actively trying to button it.
The subjective sense of ownership and control of the limb is entirely severed. The hand acts on its own volition.
And then there are delusional syndromes. There is a fascinating point here about how organic brain damage breeds very specific, structured types of delusions rather than just random paranoia. Let's talk about Capgras syndrome.
Capgras is the delusion of misidentification. The patient looks at their spouse, their child, or even their pet and believes with absolute, unshakable certainty that their loved one has been replaced by an identical imposter.
And the neuropsychiatric explanation for this is a severed connection. Let's map it because it's brilliant. I like to think of Capgras as a reverse déjà vu.
Okay, I like that.
In déjà vu, you are in a completely novel situation, but you have an overwhelming, unearned emotional sense of familiarity. Familiarity without recognition. In Capgras, it's the exact opposite mechanism.
That is a perfect analogy. In Capgras syndrome, the patient has perfect perceptual recognition.
The visual cortex sees the face, processes the geometric features, and says, that looks exactly like my wife. The eyes are the same, the hair is the same.
But the deep white matter pathway connecting that visual recognition area to the limbic system, specifically the amygdala, which provides the warm emotional glow of familiarity, is severed by a lesion or neurodegeneration.
Recognition without familiarity.
Yes. So the brain is faced with an impossible, terrifying paradox. The visual data says it looks exactly like my wife, but the emotional data says I feel absolutely nothing for this person. She is a stranger.
The brain cannot tolerate this contradiction. So, to resolve the cognitive dissonance, the brain fabricates a delusion to explain it.
It must be an imposter. It looks like her, but it isn't her. The exact same hardware mechanism failing in opposite directions produces déjà vu and Capgras syndrome.
To figure all of this out, to find these lesions and severed connections, we need paraclinical investigations.
Imaging is obvious. A CT scan if you need it fast in the ER to look for blood or bone fractures, an MRI for detailed, high-resolution tissue analysis.
But what really stands out in modern neuropsychiatry is the rise of autoimmune encephalopathies.
This discovery has completely revolutionized psychiatry in the last 15 years. We are finding patients, often young people, who present to the hospital with acute, severe, first-episode psychosis.
Terrifying hallucinations, extreme paranoia, erratic behavior, sometimes descending into catatonia.
In the past, they would have been diagnosed with rapid-onset schizophrenia, but they do not have schizophrenia. They have a rogue immune system.
They have antibodies aggressively attacking their own brain receptors. The most famous is anti-NMDA receptor encephalitis.
And the mechanism behind this is wild. It often involves an ovarian teratoma, right?
Often, yes. A teratoma is a type of tumor that can contain various types of tissue, including, bizarrely, brain-like neural tissue.
If a young woman develops an ovarian teratoma containing NMDA receptors, her immune system recognizes the tumor as foreign and mounts an attack, creating antibodies against those receptors.
But those antibodies don't just stay in the ovary. They cross the blood-brain barrier, and they find the actual healthy NMDA receptors in the patient's brain, and they attack them too.
The immune system friendly fires the brain, causing massive acute psychosis.
So how do you find that out? How do you catch it before you lock them in a psych ward?
You often have to perform a lumbar puncture. You must test the cerebrospinal fluid, the CSF that bathes the brain.
Because in many cases, the serum, the blood drawn from their arm, will be totally negative for the antibodies, but the CSF will be positive.
If you miss it, if you don't do the tap, you can sign a patient to a lifetime of heavy antipsychotics for a psychiatric disease they don't have.
When what they actually need is immunotherapy, steroids, or tumor removal to completely cure them.
The body literally attacking the fault line. Which brings us to the final and perhaps most complex topic in the clinical evaluation: conversion disorder or functional neurologic symptom disorder.
This is a challenging area. This is when a patient presents with dramatic symptoms that look exactly like organic brain disease: complete paralysis of a limb, blindness, profound non-epileptic seizures. But when you run the MRI, the EEG, the reflex tests, the neurological wiring is entirely structurally intact.
And the neuropsychiatrist must take a very clear, scientifically grounded stance here. There is a specific bedside test mentioned, the Hoover sign. Let's explain how this works.
Let's say a patient is lying in a hospital bed and claims their right leg is completely paralyzed. They cannot move it at all.
The examiner places their hand under the heel of the weak right leg and asks the patient to press down into their hand. The patient tries, but they generate zero power.
Then the examiner asks the patient to lift their left perfectly healthy leg straight up in the air against the examiner's resistance.
And what happens mechanically?
By automatic involuntary biomechanical synergy, when you powerfully lift one leg up, your body forces the other leg to push down to stabilize your pelvis. It's a hardwired reflex.
When the patient lifts their good left leg, the examiner will feel the paralyzed right heel push down firmly and powerfully into their hand. The motor pathway from the brain down the spinal cord to the leg is unequivocally intact.
Now, a cynical doctor, or anyone watching this, might say, you're faking it. You just push down. You're a liar.
And this is where the philosophy of neuropsychiatry is paramount. That reaction is a catastrophic countertherapeutic trap. Malingering is a deliberate, conscious deception for secondary gain, like trying to get insurance payout or avoid jail time.
Conversion disorder is an entirely unconscious process. The Hoover sign does not prove the patient is lying. It demonstrates a physiological reality. The structural pathways work.
But the patient has a genuine disorder of symbolic function. Their severe psychological distress, often rooted in profound trauma or adversity, is being unconsciously converted into a physical symptom because the brain lacks a better, safer avenue for emotional expression.
So the goal of the Hoover sign isn't to play gotcha and expose a fraud. The goal is to establish a foundation of good news.
To say the hardware is intact, the nerves aren't dead, which is wonderful. Now let's work together to figure out what is really causing this system overload in the software.
Exactly. It requires intellectual humility. It requires a recognition that the human mind has incredibly powerful, sometimes baffling ways of manifesting emotional distress through physical biology.
It is not a fake illness. It is a real illness requiring a different mechanism of healing.
Synthesizing this entire incredible journey, the neuropsychiatric approach is clearly not just a niche subspecialty where you refer the weird, difficult cases. It is a fundamental way of seeing every single patient.
It integrates the structure of the brain with the narrative of the person. Symptoms are understood simultaneously as dysfunctions of neural circuits and as subjective experiences embedded in a life.
Reductionism, saying it's just biology or just psychology, is the ultimate enemy here.
Well said. To truly understand the patient, you must give equal, rigorous attention to both the structural anatomy and the personal narrative. Biology and meaning both matter. You cannot separate the instrument from the song.
Which leaves me with a final provocative thought to leave you with.
I'm intrigued.
If a microscopic lesion in a specific white matter tract can completely sever our ability to feel love for our spouse's face in Capgras syndrome, or if damage to a tiny loop of spindle cells can erase our ability to initiate our own free will in akinetic mutism, where exactly does the self reside?
We are building these vast, beautiful cities of personality, memory, and identity directly on top of shifting tectonic plates of biology.
And neuropsychiatry shows us exactly where the fault lines lie.
It is a profound mystery and a beautiful challenge for anyone in this field to mull over.
Now, to reinforce everything we've unpacked today, we have prepared 5 single best answer questions to test your clinical reasoning. Let's dive in.
Let's do it.
Question 1. A 45-year-old right-handed patient suffers a stroke involving the right insular cortex. Based on the lateralization of autonomic control, what physiological consequence is most highly associated with this specific lesion location compared to a left-sided lesion? A. Increased parasympathetic drive. B. Severe cardiac destabilization. C. Impairment of visual guidance. D. Alterations in sympathetic drive. E. Development of gelastic epilepsy.
The correct answer is D. The reasoning here is based on the specific lateralized role of the insula. The right insula regulates sympathetic drive, while the left regulates parasympathetic. If the question asked about a left-sided stroke, the answer would involve severe cardiac destabilization due to the resulting unopposed sympathetic tone. But for the right insula, D is the most accurate reflection of its specific autonomic function.
Question 2. A patient presents with a profound lack of motivation, reduced goal-directed behavior, and a flat affect following a subcortical stroke. However, they strongly deny feeling any sadness, guilt, or emotional distress. Which fronto-subcortical circuit is most likely disrupted in this patient? A. Dorsolateral prefrontal circuit. B. Medial orbitofrontal circuit. C. Dorsomedial prefrontal circuit. D. Parpez circuit. E. Lateral orbitofrontal circuit.
The correct answer is C. Damage to the dorsomedial prefrontal or anterior cingulate circuit, the brain's starter motor, produces apathy, abulia, and akinetic mutism. This is a state of mental emptiness and a failure to initiate action, which is clinically and anatomically distinct from the mental distress and psychic pain found in depression.
Question 3. During a bedside mental state examination, the examiner takes out a pen and places it casually on the desk. The patient immediately reaches out, picks up the pen, and begins scribbling on the examiner's notepad without being asked or prompted. What is this sign called, and what underlying deficit does it indicate? A. Motor impersistence, right hemisphere dysfunction. B. Utilization behavior, failure of executive inhibition. C. Echopraxia, dorsolateral prefrontal circuit damage. D. Alien hand syndrome, corpus callosum disconnection. E. Balance syndrome, superior parietal damage.
The correct answer is B. This is utilization behavior. It represents an automatic, environmentally bound tendency to use objects appropriately, but in an entirely inappropriate social context. It results from an executive failure of the orbitofrontal circuits, which are no longer able to inhibit the action.
Question 4. A patient is evaluated for severe reading difficulties following a left posterior cerebral artery occlusion. The patient is completely unable to read words on a page, but can easily write a coherent sentence when asked. What anatomical mechanism explains this highly specific deficit, known as alexia without agraphia? A. Damage to Broca's area and the arcuate fasciculus. B. Disconnection of the left language cortices from visual input due to damage to the left visual cortex and splenium. C. Anterior callosal infarction cutting off verbal information to the right hemisphere. D. Bilateral lesions of the primary auditory cortex. E. Crossed cerebellar dysgenesis affecting the visual cortex.
The correct answer is B. A left PCA stroke destroys the left visual cortex, blinding the right visual field. Crucially, it also destroys the splenium of the corpus callosum, which cuts off the crossing visual input from the intact right visual cortex. The language centrals in the left hemisphere remain perfectly intact for motor output, so writing is preserved, but they are physically disconnected from receiving any visual input to read.
Question 5. A patient complaining of severe right leg weakness is tested using the Hoover sign. When asked to press down with the affected right heel, they generate no power. However, when asked to list their contralateral good left leg against the examiner's resistance, the examiner feels an automatic synergistic downward pressure from the weak right heel. What is the most clinically appropriate interpretation of this physical finding? A. The patient is deliberately malingering for secondary gain. B. The patient has an acquired pyramidal motor syndrome. C. The patient has a functional neurologic symptom disorder reflecting a disorder of symbolic function. D. The patient has crossed cerebellar diasgenesis. E. The patient has damage to the supplementary motor area.
The correct answer is C. The Hoover sign reveals non-physiologic weakness, which is indicative of a conversion or functional disorder. A core tenet of the neuropsychiatric approach is to avoid interpreting this merely as deliberate falsification or malingering. It is framed instead as a genuine, unconscious disorder of symbolic function that requires psychological investigation and a strong therapeutic alliance, not an accusation of lying.
Excellent. I highly encourage everyone listening to return to Chapter 2.1 to read alongside the concepts we've discussed and really cement these mental models in your clinical reasoning.
Yes, it's brilliant material. Here are the details of this episode.
The neuropsychiatric approach to the patient. Byline. At the fault line of brain and mind where biology meets lived experience.